We are going to start our lessons on cardiovascular system. The cardiovascular system include cardio, which is the heart, and the vessel, vascular. So this is a combination of organs, and that is what we call system. So now we will concentrate on the heart. Before I start, I want you to know that there are many different things in our life we need to know, and what we should be doing is like we should classify into must know, should know, and need to know. So just try to emphasize on what you really need to know and what are important to know. So I got these slides from one of the websites on the internet. So cardiovascular system, as we said, it includes the heart and the blood vessels. So if we look at the heart here, the color coded with red, which is the arterial blood, which will come out from the heart along the large vessels. This large vessel gradually gets smaller and finally become very thin out, which we call capillaries. And capillaries continue, and finally these capillaries march to form small little vein, which we call venules. And these venules will march together to form vein, and many veins form together to become a larger veins. And of course, all the venous blood will be returned to the heart, and the heart will pump out. If you see, like on the right side of the heart, pump out this deoxygenated blood, used blood from the periphery, will be pumped to the lungs, where they get reoxygenated, and this reoxygenated blood will come back to the left side of the heart. If we make a better diagram, then this is what we have seen before. We have the heart has the right side of the heart and left side of the heart. Left side of the heart, we have two chambers, left atrium and left ventricle. And on right side of the heart, we have right atrium and right ventricle. Left side of the heart has oxygenated blood, which is colored with red. This oxygenated blood will be pumped from the left ventricle into the aorta, which is the large artery just immediately coming out from the heart. And that blood will be distributed to every part of the body. And at the cellular level, these blood vessels will become capillaries, and these capillaries finally march together and they will be called venules, and venules will combine together to form small veins. Small veins will form together to become larger veins, which we call vena cava. And then we go into the right side of the heart, which is in the right atrium. What do we mean atrium? Atrium, like in other words, it is a large hall at the entrance of a building. And the same thing, the right atrium is going to accept all the blood coming back from the different part of the body. And from the right atrium, it goes through the valve, which we call tricuspid valve. And through the tricuspid valve, the blood will come into the right ventricle. The right ventricle deoxygenated blood will go through the pulmonary valves into the pulmonary trunk and finally divides into the right and left pulmonary artery. Here, we need to be aware that this pulmonary artery, which is carrying deoxygenated blood. So when do we call an artery or a vein, it is not related to the blood it carries. It doesn't matter whether it is oxygenated or deoxygenated blood. Any vessel which is leaving the heart will be called artery, and any vessel which is going into the heart will be called veins. And therefore, the right pulmonary trunk, which we divide into right and left pulmonary artery, they will carry deoxygenated blood, and oxygenated blood from the lungs will come back to the heart into the left atrium. I want you to appreciate here two on each side, two pulmonary veins, because they are coming back to the heart. On each side, we go into the left atrium. Now, once we know the general circulatory process of the cardiovascular system, let's go to the heart itself. Let's do the surface anatomy. So this is the surface anatomy of the heart. If you have to see a patient and check where the heart is, the surface anatomy become important. So let's say our heart is about the size of our fist, and it weighs about 300 grams, roughly. Of course, it has a range. And if we put our fist on our chest, this is where we should be putting. So if you look here, this is the third rib costal cartilage, which came and attached to the sternum. So on the right side, right border, it starts from the third chondral cartilage, just lateral to the sternum. On the sixth costal cartilage, just lateral to the sternum. On the left side, it starts from the second intercostal space, just lateral to the sternum, and on the fifth intercostal space, just medial to the mid-clavicular line. So if you identify these 4 points and make a boundary of it, we get where our heart is. So it is just behind the sternum, which is very close to the sternum. So now let's have a look at another diagram. So this is where our heart is. We know that already. 3, 6, second intercostal space and fifth intercostal space. On either side of the heart, we have right larynx and the left larynx. At the front, we will have mediastinum, which is, and we will have sternum. And at the back, we will have the vertebral body. So in between these boundaries, right larynx, left larynx, sternum at the front, and vertebral body at the back, the space is called mediastinum. So mediastinum is a space in our thoracic cavity, which is boundaried by right larynx, left larynx, anteriorly sternum, posteriorly vertebral body, inferiorly diaphragm. That is the space. In that mediastinum, we have our heart and the great vessels. This is the anatomy cadaver photograph. I believe if you have been to the cadaver room with me, I believe we have seen this all. And let's say if we translate that knowledge into clinical practice, this is what we are going to see. I hope you will understand. This is the heart. This is the apex of the heart. It is resting on the diaphragm. So what I want to say is we have to take this knowledge, and of course this knowledge, and we should be able to interpret this X-ray. So now have a closer look at the heart. This is the right atrium, which forms the right border of the heart. This is the right ventricle, which contributes the most of the anterior surface of the heart, as you can see, and of course, inferior border of the heart. And now we can see left ventricle, which makes the apex of the heart and left border of the heart. Left atrium, which is very small to see from the front, might contribute just a small portion. But if we want to see the left atrium, we have to look on the posterior surface of the heart. So now I want you to appreciate 4 chambers of the heart: right atrium, right ventricle, left atrium, left ventricle, and their contribution to the surface of the heart. So which means if we look at the X-ray of the chest again, now we can see the right border of the heart, which is made of right atrium. We can see the inferior boundary, inferior border of the heart, which is made of right ventricle. Most of the anterior surface of the heart, right ventricle. The apex of the heart and the left border, the left ventricle, and we might see a little bit of the left atrium. So these makes the boundaries and the borders of the heart. So now I believe this page is not difficult for you. So now let's try to listen to the heart sounds. So this is the 1898 drawing. A physician is trying to listen somebody's heart sound. Of course, that's the beginning, and that's the physician from Paris. He invented this stethoscope to start with, and finally now on the market, we have many different types of stethoscope to use. So these are the locations of the heart valves inside the heart. This is the actual location. So if you look at that, the pulmonary valve is at the top, and then followed by the aortic valve. And finally, on the right side, between the right atrium and right ventricle, we have tricuspid valve. And on the left side, we have mitral valve. This is the actual location of the sites of the heart valve in the heart. But what's happened, and when we listen to the heart sound, where do we put our stethoscope? This is where we put our stethoscopes. So the way I try to remember is on the right side of the heart, like the boundaries of the heart, as you have seen, like AT, mean aortic and tricuspid heart valve sound, and on the left side, PM. So that's second intercostal space and fifth intercostal space. So that was the surface marking of the heart. That is one of our anatomy textbook describe where to listen our heart sound. But this is one of the medical textbook which say where we should be listening to the heart valve. Not a big difference, like right second intercostal space for the aortic, left second intercostal space for the pulmonary, for the fifth intercostal space for the mitral valve. Only the tricuspid valve move from right side of the sternum towards the left side of the sternum. So I want you to appreciate, why do we get heart sounds? For the first heart sound, we hear them because of the closure of the tricuspid and mitral valve. The second heart sound happens because of the closure of the aortic and pulmonary valves. So when the heart beats, both right and left atrium will be contracting at the same time. The blood from the atrium go into the ventricle through the tricuspid and mitral valve. And then when the atrium relaxes, the ventricles are filled with blood already. Now they start contracting, and tricuspid and mitral valve we close to start with. And then once the pressure increase, the blood from the ventricles will go through the aortic and pulmonary valve. When the ventricle relax, the blood flow will gradually decrease and aortic and pulmonary valve closed. Closure of the valve makes the heart sound. The first heart sound we hear is caused by the mitral and tricuspid valve closure. And again, the second heart sound we hear is the closure of the aortic and pulmonary valve. This is the usual description of the heart sounds, like lap and dap, lap and dap, first heart sound and second heart sound. And these are the places where we should be listening these heart sounds. This is electrocardiogram, EKG. An electrocardiogram is, again, like pretty simple concept. It is just trying to look at the heart from 12 different angles. So what we have learned so far, we have learned the anatomical location and the mediastinum. We have learned the chambers of the heart. We have talked about the blood flow through the heart, meaning starting from all the bloods entering into the right atrium, through the tricuspid valve, we go into the right ventricle, from the right ventricle through the pulmonary valve. Deoxygenated blood will go to the lungs, get reoxygenated. From the lungs, the blood will come back to the heart through the pulmonary vein into the left atrium. From the left atrium, it will go through mitral valve into the left ventricle. From the left ventricle, blood will be ejected out into the aorta through the aortic valve. And we talk about heart sound, we talk about location of the heart valves. Here, I want you to take a break. I want you to go back to previous slide before we go to next slides. I hope you get a chance to review previous slides. And now let's move on. So this is the histology slide for the cardiac muscle, which is a striated muscle. But this might be a bit more clear for us because you can see the cardiac muscle fibers are running, but at the same time, we can see the branching muscles here, and we can see the convergence of the muscles. Divide here and combine. That is the feature of cardiac muscle, and we can still see some striations here. And now we start seeing these little black lines, and these are the intercalated disc. Intercalated disc is the junction between one cardiac muscle cell and another. And we can see now nucleus. So let's talk about cardiac muscle. We talk about this when we were doing cell and tissue lecture. So cardiac muscle is a striated muscle. It has some similarity to skeletal muscle because of the striations, but their characteristics, they are short, they are branching, and they are fusing as well, branch and unite. There will be one or two centrally located nuclei. And you have seen intercalated disc, that is the junction of the cardiac mast cells. If we look at the intercalated region more carefully in next slides, we will see two regions, transverse region and longitudinal region. Transverse region has fascia adherens, which is also called desmosomes, which will keep cardiac mast cells together. Adherens mean adhere. And gap junction, where we transmit electrical or ion signals in between the cardiac mast cells. Let's go and have a look at that. So this is the cardiac mast cell. Because it has striations, it is dividing and it is uniting. And at the junction of each cardiac mast cells, you will see the intercalated disc, that is the junction between one cardiac mast cell and another cardiac mast cell. And you will see a centrally located nucleus. You will see T-tubules, sarcoplasmic reticulum, the way we see in our skeletal muscle. They also have I-band, A-band, Z-disc, but they are less prominent. So it is pretty similar to skeletal muscle. And now if we look at the intercalated disc region, we will see the gap junctions and fascia adherens, which is also called desmosomes. These desmosomes keep the cardiac mast cells together, and gap junctions will allow the ions crossing from one cell to another. The significance of cardiac mast cells are they will have large number of mitochondria, like about 25 to 35% of the volume of cardiac cells is filled with mitochondria, because these cardiac mast cells are produce ATP via oxidative process. Therefore, they are very much oxygen dependent. But on the other hand, the pros of oxidative mast fibers, they are fatigue resistant, and therefore the heart will beat for a long period without tiring. And on top of that, the heart contains two kinds of myocytes, mast cells. The first one is the myocytes that we just contract, so contractile cardiac mast cells, contractile myocytes, which are just responsible for the pumping of the heart. Another cardiac myocyte, another cardiac mast cell is the special type, which is they are not going to contract, but they are going to create electrical stimulus, which we call the pacemaker cells of the heart, and that will spontaneously depolarize. And because of this, the heart can beat on its own without having influence from the brain or the spinal cord. So the heart can beat on its own, even if we remove it, because of the specialized non-contractile myocytes in the heart, which we call pacemaker cells. The heart will continue to beat, and the contractile mast cells, which is almost all of the myocytes except the non-contractile cells. Just looking at the gap junction and desmosomes again, and what they do. So now I got this from the website, again, like James Fraser. like he's saying, like second principle, I want you to have a read and think what we are saying. Of course, we were talking about cardiovascular system. There are many different things we need to know. And on top of that, we need to know a lot more as the semesters goes on. And we have studied many different things already. So, it is just for the semester. At some point, you will forget about that. But if you have studied really well in a few months to years' time, and when you have to study again, I believe everything will come back much easier. So now let's look at the direction of the cardiac muscles. If you look on the upper side, which is the right atrium side and left atrium sides, the muscles are very much circular in nature. You can see that. When it comes to the ventricle, it is more spiral. This is the arrangement of the cardiac muscles. So therefore, when the right atrium or the left atrium contract, then because of the arrangement of these muscle fibers, which is in circular, they will eject blood from the atrium down to the ventricle. And because of the spiral arrangement of the ventricular muscle fibers, with the contraction, the left ventricle will eject blood into the aorta, which is more on the right side of the heart. And the same, like the blood from the right ventricle will go into the pulmonary tract, which is more or less on the left side. The cardiac skeleton, as I have described here, it is the dense connective tissue where the muscles, heart valves come and attach, and it has the ability to limit the over distension of the heart. It is a dense connective tissue. It's a dense connective tissue. It reinforces the myocardium inside. It gives the attachment for the cardiac muscle fibers. It gives attachment of the heart valves inside the heart. It prevents over-dilatation of the valves. And it blocks the conduction of electric impulse from the atrium to the ventricle, so that the electrical impulse can go from the atrium to the ventricle just along the programmed pathway. That is the job of the cardiac skeleton. Of course, it is not really a bone. It is just made of the dense connective tissue. So now we believe we have understand what the mediastinum is, where the mediastinum is, and we know about the muscles of the heart. If we look at this diagram again, like we are going to look at the blood supply for the heart. Now here we can see a groove on the right, which is in between the right atrium and right ventricle. And we can see another groove between the left atrium and left ventricle. This is like a circular arrangement on the upper half of the heart, which is like a crown on the head. The crown, in other words, is called corona, and therefore these grooves are called coronary sulcus. Sulcus means groove. And inside the coronary groove on the right side, we have right coronary artery. On the left coronary sulcus, we have left coronary artery. These coronary arteries, they are originating from the aorta, which is the big blood vessel just coming out from the left ventricle. These coronary arteries, if you look at that, it is just running in between the right atrium and right ventricle, right coronary artery, originating from the aorta. And we have the left coronary artery, which is originating from the aorta and running in the left coronary sulcus. So now let's try to chase the right coronary artery. As you can see, it is running in between the atrium on the right and right ventricle. It is going to give blood supply to these chambers, right atrium and right ventricle. At the inferior border, it gives us a branch here, which is the marginal artery. And then this right coronary artery continues, loop around the border and continue in the posterior aspect of the heart. Left coronary artery, once it comes out from the aorta, it divides into two branches. One going to backwards, curve backwards, which is called circumflex artery, and another vessel which is running in between the right ventricle and left ventricle. Of course, it is running in between two ventricles. We call it interventricular artery. It is in the front of the heart, and therefore, to be more precise, we should call anterior interventricular artery. And the left coronary artery just continue and as a circumflex artery and go and loop to the back of the heart. Let's have a look at the posterior surface of the heart. Now we can see the right coronary artery coming back here, and it continues, and finally it runs in between the right ventricle and left ventricle, and it is on the posterior surface of the heart. Therefore, let's call it posterior interventricular artery. And now you can see the circumflex artery, which is coming and turning to the back of the heart. So this is the arterial circulation of the heart. And now I want you to appreciate the pulmonary veins, which are coming back from the lungs, which is two on the right and two on the left. So there we are, 4 pulmonary veins, which are carrying the oxygenated blood and taking the oxygenated blood from the lungs to the left atrium. Let's stay here with the coronary arteries, and I want you to take a break. I want you to go back to this diagram and study this diagram a little bit more. And finally, I want you to draw this just like a very free body diagram. From the aorta, right coronary artery come out, left coronary artery come out, left coronary artery, we continue, and circumflex artery, which we go in between the right and left atrium, interventricular artery. The right coronary artery, we give right marginal artery, and it will continue as a posterior interventricular artery. So I want you to draw this diagram. And again, like I want you to look at this picture, appreciate the aorta and the pulmonary trunk, which we divide into right pulmonary artery and left pulmonary artery. And pulmonary trunk is arising from the right ventricle, large aorta, which is going to take oxygenated blood to every part of the body, originate from the left ventricle, and in between ventricles, anteriorly, anterior interventricular artery. In between the right atrium and right ventricle, we have right coronary artery, and we can see the right marginal artery. Now, let's go and summarize the arteries. Anterior interventricular artery, of course, it will give blood supply to the anterior wall of the heart, and interventricular septum. Inter, I-N-T-E-R, ventricle, V-E-N-T-R-I-C-L-E, C-U-L-A-R, interventricular septum, S-E-P-T-U-M, anterior interventricular septum. Circumflex artery, as you see, it is just looping on the lateral border of the heart and going back to the posterior surface of the heart. And therefore, it will give blood supply to the posterior wall of the heart, which is made of left atrium and left ventricle posterior wall. As you see, right coronary artery will give blood supply to the right atrium and right ventricle because it is running in between two chambers. If we look at the venous return of the heart, you will see great vessels, middle, small, and posterior cardiac veins. Great cardiac vein, middle cardiac vein, and small cardiac vein, and posterior cardiac vein, they will all go into the coronary circus. So let's go and look at this cardiac veins here. As you can see here, the great cardiac vein, which is just here, following the anterior interventricular artery. Middle cardiac vein, which is following the posterior interventricular artery. And there is one vein for the left ventricle, which we call posterior vein of the left ventricle. So we have seen great cardiac vein, middle cardiac vein, and small cardiac vein, which is following the marginal artery. And finally, they will all drain into the large vein on the posterior surface of the heart, which we call coronary sinus. And this coronary sinus will go into the right atrium. So now this completes the blood supply of the heart. I want you to take a break. I want you to go back to previous lecture slides and step. Now let's open the heart and look inside the heart. We will see 4 chambers. As you remember, right atrium, where all the blood from the whole body via the superior vena cava and inferior vena cava, we go back into the heart. That chamber is called right atrium. And from the right atrium, the blood will enter into the right ventricle via a valve through an opening which is guarded by a valve, which is called tricuspid valve. And the blood now, the oxygenated blood, will stay in the right ventricle. And the ventricle will pump out this blood into the pulmonary trunk and goes to the right pulmonary artery and left pulmonary artery to the lungs. And here, the blood has to go through another aperture, which is guarded by another valve, which we call pulmonary valve. And once the blood reoxygenated in the lungs, it comes back to the left side of the heart into the left atrium. From the left atrium, the blood will go into the left ventricle. And these 2 chambers are separated by a valve, which is called the mitral valve. Mitral valve. And the left atrial blood, now oxygenated blood already, will go into the aorta through the aortic valve, which is somewhere around here. So now, if we look at the diagram, let's take our time to study this. The importance we can see is the interior surface of the atrium, both on right and the left. It is very smooth. Interior surface of the ventricles, which is rough, as you can see here. You can see the myocardial wall, which is running like a mountain ridges, and they are called trabecular carneum. So this is the muscle ridges in the interior surface of the ventricles. And you will also notice papillary muscles here, papillary muscles in the interior surface of the heart. They are connecting the muscle wall and the heart valves and via the chordae tendineae. So now look at that. This is the chordae tendineae, which is the tendinous structure, which is joining the margins of the heart valve to the papillary artery, papillary muscles. What they do is when the ventricles contract, when the ventricles squeeze, once the pressure rises inside the ventricle, the tricuspid and mitral valve will close. And because these papillary muscles acting together with the chordae tendineae, it will prevent prolapse of the heart valve because of the ventricular contraction. If we do not have these, the margins of the heart valve may prolapse into the opposite atriums. So this chordae tendineae will hold the tricuspid and mitral valve so that they do not prolapse into the other chambers with the rise of the pressure in the ventricle. We do not have that in the pulmonary valve. We do not have that in the aortic valve. So these are the significant features from this diagram. And if we go a little bit more detail, the whole of the left atrium has a smooth surface. But now, if you look more carefully in the right atrium, the posterior surface is smooth. And now we can start seeing like more anterior surface is slightly rough surface. So I hope you can appreciate the four chambers of the heart and difference between the four chambers of the heart. And again, like the muscle thickness of the left ventricle is really thick because it has to pump with the significant pressure, because when the ventricles are contracting, ejecting blood, it will go into the systemic circulation and there will be resistance. That resistance, it is like systolic blood pressure, at least 110, 120 in general population. The right ventricle, which has to pump blood into the pulmonary circulation, which is less pressure resistance, and therefore right ventricular wall thickness is much less than the left ventricular wall. This is the diagram to appreciate the thickness of the right and left ventricles. So now let's talk about the walls of the heart. Before we talk about the muscle walls, the walls of the heart, let's have a brief look about the blood vessels walls. Almost all blood vessels walls have three layers. Innermost layer is called tunica intima. The middle layer is called tunica media. and outermost layer is called tunica adventitia. So we have this arrangement in every vessels, either artery or vein. Of course, depending on what type of artery or whether it is a vein or artery, there will be some difference. But generally, all the blood vessels, artery or vein, are arranged in 3 layers: innermost, tunica intima; middle, tunica media; and outermost, tunica adventitia. And of course, this is the lumen where our blood flows. So the same thing we will see in the heart. The heart is covered with the fibrous and serous pericardium. Peri mean around, cardium mean cardiac, pericardium. Fibrous pericardium will keep the heart in the mediastinum at its own position. It is a dense fibrous tissue. So its job is to keep the heart in its position in the mediastinum. Serous pericardium has 2 layers, which has visceral pericardium, which is also called epicardium, and the outer layer, which is called parietal pericardium. So the parietal pericardium will line the inner layer, inner surface of the fibrous pericardium, and visceral pericardium, which is also called epicardium, will lie on the outer surface of the cardiac muscle. And layers of the heart wall are made of endocardium, myocardium, and epicardium, which is the same like the way we said in the blood vessel: endocardium, myocardium, and tunica intima, media, adventitia. The same thing, tunica intima, which is made of endothelial cell in the blood vessel, and this is made of endocardium in the heart, myocardium, mast cells, and the epicardium, which is the outer layer, which is the visceral layer of the serous pericardium. So I want you to take your time to look at this diagram, and I want you to try to understand. Of course, this is the inside the heart, which is the chamber where our heart, blood is. And the most intimate layer with the blood of the heart wall is the endocardium. And now we have the myocardium. And on top of that, we have the epicardium, which is the visceral layer of the serous pericardium, which reflects and continue and line the inner surface of the fibrous pericardium. And this layer, parietal layer of the serous pericardium here. So I want you to take your time, have a look, and study. And now, because of that, now if we look at that, the layers of the heart, innermost endocardium, myocardium, mast layer, and the epicardium, which is made of the visceral layer of the serous pericardium. And this visceral layer will reflect and continue as the parietal layer of the serous pericardium, which is going to line the inner surface of the fibrous pericardium. So now we have created a space between the parietal and visceral layers of the serous pericardium, and this space is called pericardial cavity. And pericardial cavity is usually filled with a very small amount of pericardial fluid. Of course, if there is any issue, like for example, viral infection, there is excessive pericardial fluid accumulation in the pericardial cavity, and that is what we call pericardial effusion, EFFU-SION. Now, if we have the pericardial effusion, we can see fluid in between the parietal and visceral layers of the serous pericardium, which will have effect on compressing on the heart. That will be very difficult for the heart to beat. That is what we call a condition, cardiac tamponade. So now let's go back to this diagram. I believe you know how the blood flow through the heart and then come back to the heart. So now let's have a look. Let's go into detail about that diagram. So the blood from every part of the body, from head and neck region, upper limb, it will come back into the right side of the heart, right atrium, via the superior vena cava, and all the blood from the lower part of the body, limbs, abdomen, can combine together, inferior vena cava. They will both drain into the right atrium. And now it has to go through the tricuspid valve, come into the, now blood is accumulated in the right atrium, and now it has to go through the tricuspid valve into the right ventricle. Now right ventricle is full already, and now starting to eject blood out of the right ventricle through the pulmonary valve. Now it's leaving, and now it will go to the lungs, get reoxygenated, and this reoxygenated blood will come back to the left atrium here, and now left atrium is filled with oxygenated blood already. Through the mitral valve, it will go into the left ventricle, and now the left ventricle contract and eject blood from the left ventricle into the aorta. So this is a very good diagram which shows the flow of the heart in the human body. Let's look at the heart valves, the shape of the heart valves carefully. Now, if you look at that, what is significant is only 1 out of 4 heart valve has 2 leaflets. That is the mitral valve. Mitral valve has only 2 leaflets, as you can see. Tricuspid valve, as the name says, 3 valves. Aortic valve also has 3 valves, and pulmonary valve also has 3 valves. And therefore, let's say all the heart valves has 3 leaflets except the mitral valve. Mitral, it is the, like this shape here, and the mitral heart valve has only 2 leaflets. Now I want you to take a break again and go back and study the previous slides. I hope you have a break. Let's move on to the next slides. So now we will go back and look at the valves again. We can now appreciate the tricuspid valve, which guards the opening between the right atrium and right ventricle, and mitral valve, which is guarding the aperture between the left atrium and left ventricle. And they do have chordae tendineae and attaching to the papillary muscles. And we can also see the trabeculae canae, which is the muscle ridges inside the wall of the heart chambers. And the heart wall has 3 layers: inner endocardium, middle muscle layer, myocardium, and outer epicardium, which is the visceral layer of the parietal pericardium. Sorry. Beg your pardon. Visceral layer of the serous pericardium. And now we can see the smooth surface of the inside of the atriums. And we can see openings of the main blood vessels coming back into the heart. And part of the right atrium has some roughness as well. And now this is the interventricular septum, INTER, interventricular, VENTRICULAR, interventricular septum, SEPTUM. This is the septum which is separating the right ventricle and left ventricle, interventricular septum. And now the functions of the atrioventricular valves, which is the tricuspid and mitral valve. Let's try to understand again. When the ventricles contract, forcing the blood against the AV valve caps. So now once the pressure rises in the ventricles, the atrioventricular valves, which are the tricuspid and mitral valve, will be pushed up. And therefore, AV valve will close. The papillary muscles, as you see from the previous diagram, contract, and chordae tighten, preventing the valve flap from evading into the opposite chamber, which is the atria. So that is the job of the chordae tendineae and papillary muscles. Let's open into the right atrium of the heart. As you can see, most of the posterior surface of the right atrium is smooth, but we saw some part, which is now we can see anterior surface of the right atrium has some roughness. We can see the fossa ovalis and we can see the interatrial septum. So this is the partition between the right atrium and left atrium. And we can also see the coronary sinus, which we saw like on the posterior surface of the heart, which carries all the blood from the heart back into the right atrium, its entrance here. Now this is a drawing which we see the fossa ovalis here and the entrance of the superior vena cava, entrance of the posterior vena cava, opening of the coronary sinus, which is anterior to the fossa ovalis, as you can see here. So now, what do we know about right atrium? We know that right atrium forms the right border of the heart. Its walls are smooth in the posterior part. In the anterior part, we can see some ridges, which we call pectinate muscles. It is separated by the crista terminalis, as you see here. Crista terminalis is here, which is marked here. So crista terminalis divide the posterior smooth surface and anterior rough surface. And fossa ovalis is just posterior to the crista terminalis. Now, let's look at the more detail, like right atrium. You can see the fossa ovalis and the pectinate muscle here on the anterior wall, and you can see the smooth posterior surface. What do we know about right ventricle? It is the most anterior surface of the heart. We saw the papillary muscle, chordae tendineae, and trabeculae carneae. And now we can appreciate the wall thickness, which is bigger than the atrium, but it's not comparable to the left ventricular wall. We have seen all these already. I want you to take your time, look at this again. And this is the photograph. You can see the chordae tendineae, which are coming from the papillary muscle, go and attach to the margins of the heart valves. And you can see the muscle ridges inside the wall of the heart, which we call trabeculae carneae. And the job of this chordae tendineae and papillary muscle is when the valve close, being pushed to the opposite side, they will hold the margins of the heart to prevent the prolapse of the valve into the opposite chamber. So this is a drawing like when the right ventricle contracts, this heart right tricuspid valve will get closed, and because of the closure, the pressure inside the ventricle will increase more, and it will push the pulmonary valve to go into the lungs. And now, if we look at that, the blood is flowing through the aortic valve here, the valves open, and now once the ventricles relax, these valves will close again. So the function of the heart valve is to open when the blood flows, when the ventricle contracts, and once the ventricle stop contracting, they have to close the valve again to prevent backflow of the blood into the chamber. If there is any incompetency of the valve, there will be valve incompetence medical issues. Left atrium, most of the posterior surface of the heart, it's smooth inside. Pectinic muscles, which is present on the right ventricle, also present in the left atrium, but only in a small portion, and that is where we call the area auricle. Left ventricles, as we know, forms the apex of the heart and most of the inferior surface of the heart. It has got like a right ventricle, papillary muscle, chordae tendineae, and trabeculae carneae. Valve disorder, as we saw, incompetency, means the valve which is supposed to block the backward flow of the heart. If it cannot do the job, it will create incompetent problem. The valves will be narrow, which is called stenosis of the valve. Because of the damage to the chordae tendineae, it can prolapse to the atrium, which is called prolapse of the valve. What is a heart murmur? Heart murmur is not heart sound. Heart sound is what we hear as first and second heart sound, lap and dub. Murmur is audible turbulent flow of the blood. I hope you might want to take a break again, because we are now going to the nervous supply to the heart. So now let's look at that. This is our heart, as we know, and we have two color coded, one with green and one with blue. So now let's trace the blue one first. It starts from the dorsal motor nucleus of the vagus. So this is the vagus nerve, the blue color. The vagus nerve is 10th cranial nerve, which starts from the dorsal motor nucleus. The vagus nerve, which function is parasympathetic function, decrease the heart rate. So vagus nerve decrease the heart rate. It is the 10th cranial nerve, which is originating from the dorsal motor nucleus of the and dorsal motor nucleus, which is here very close to the cardio-inhibitory center. So it has the negative, it slows down the heart rate. And now if you look at that thoracic spinal cord, here anterior motor neuron come out, sympathetic nerve trunk, which will come to the heart, and it has the stimulatory effect, which increase the rate and force of contraction of the heart. So I want you to remember the heart is supplied by the vagus nerve, which will slow down the heart rate, and the heart is supplied by sympathetic fibers, which will increase the rate and force of the heart rate. Contraction inside the heart, as we know, there are two types of myocytes, muscle cells in the heart. One is the contractile muscle cells, which will just contract and pump the blood. And the other one is the pacemaker, which has got self-stimulatory depolarization and excitation for the heart muscle. So this is the SA node, which is the pacemaker of the heart. It is located in the right atrium, just inferior to the entrance of the superior vena cava. So we saw that superior vena cava entrance already. And it will go through the internodal pathway to the AV node. And from AV node, it will go to the AV bundle of His, and then go to both right and left bundles and Purkinje fibers. What am I talking about? I hope you will be more clear when we see this. So this is in the right atrium. This is the opening of the superior vena cava. And just underneath, there will be sinoatrial node, which is in short SA node. From the SA node, it will go to the AV bundle. And now here, that's AV bundle, we split into right bundle and left bundle. And these bundles will gradually split and end as Purkinje fibers. So now let's look at that. The SA node start to activate. It spread all part of the atrium. And because of this, if we compare to the EKG, because of the atrial contraction on both right atrium and left atrium, we have the P wave on EKG. And now, if you look at that, the blood here in the atrium are starting to flow into the ventricles. And now, the electrical activity through the AV bundle of His, and split into the right and left, and then this way spread along the Purkinje fibers. And because of the spread of this electrical activity, it will stimulate the right ventricle and left ventricle so that the ventricle will contract. The contraction of the ventricles will cause the QRS wave here. So that is where the way we relate the contraction of the heart towards the EKG. And now the ventricles starting to a resting stage, which we call depolarization, and it is in the plateau stage in EKG. And now the ventricle repolarize again. Gradually, and that little electricity causes the T wave, ventricular repolarization. Of course, this is just for the interest and try to relate our heart activity, heart electrical contraction with the EKG. And this is not an EKG class. But what we need to know is this diagram, our sinoatrial nodes, which is just on the lower margin of the entrance of the superior vena cava into the right atrium. And via the internodal pathway, it will go to the AV node, atrioventricular node. You can see the yellow line going here to the AV node. And at the same time, from SA node, the electrical depolarization will spread to every part of the atrium, both right and left side. And now electrical activity got to the AV node. From the AV node, we go into the AV bundle, which we split into the right and left bundles. And these bundles will finally end up as Purkinje fibers that will cause the electrical stimulatory effect on the ventricles. And we have seen this diagram. That is the one we have seen is the cardiac myocyte, which are acting as pacemaker, which is going to beat on their own. And this contraction, like this electricity depolarization, is governed from outside as well, which is the vagus nerve and the sympathetic tract. Let's talk about congenital heart disease. So yes, we are coming close to the end of the heart lecture. So congenital heart disease, it happens in about 1 in 150 newborn. So congenital means the condition, the baby is born with that condition. So it happened in 1 in 150 because of the defect in the endothelial tubes. So the heart forms sinus venosus, atrium, ventricles, bulbous cortex, cardiac cushions. So that is the development of the heart. I don't think you need to know, but it is like nice to know. At day 20, endothelial tubes begin to fuse, so 2 endothelial tubes fuse. And now right and left endothelial tubes become one single structure. And finally, the heart start to twist. And on day 28, it is really twisting. And on day 35 of the intrauterine life, it becomes a heart shape. So all these sinus venosus, atrium, ventricles, bulbous cortex, cardiac cushion, they all develop there. And this is the mechanical heart valves, which we used to use, or which is some of them are still being used to replace the damaged heart valves. And this is one of the conditions where the interventricular septum, as you can remember, has defect, and the blood from the higher pressure left ventricle is entering into the right ventricle. And that means there will be volume overload in the right ventricle. And if you look at this diagram again, the aorta, the blood from the aorta should be coming from the left ventricle, and pulmonary should be coming from the right ventricle. Now, the great vessels are transposition. So the aorta is transposition to the right ventricle, and the pulmonary artery is transposition to the left ventricle. This is the sites of the heart valves. And now we can appreciate this. And now if you look at that, everything is good except the aorta, which has a very narrowed part. And therefore, the blood cannot go through this narrow part as normal. And this is a tetralogy of Fallot, in which there is a ventricular septal defect, and the pulmonary valve is narrow. So the blood from the right ventricle has more pressure going through the pulmonary valve. And therefore, the right ventricle blood will go through the ventricular septal defect and will go into the left ventricle. And therefore, in the left ventricle blood will be mixed with oxygenated and deoxygenated blood. So a few less lecture, guys. Don't worry too much about the EKG, but I want to give you some basic knowledge. In standard EKG, there will be 12 leads like AVR, augmented vector right, AVL, augmented vector left, and AVF, augmented vector foot. It is looking at the heart from 3 different directions. And if we look at the lead 1, lead 2, lead 3, again, looking at the heart from like 0, 60 to 120 degree. And this is the anterior leads, which is just on the anterior surface of the heart. From the right to the left, we call V1, V2, down to V6. And I hope we talk a little bit about P wave, which is the depolarization of the ventricles, both right and left, and then depolarization of the ventricles, which create QRS, and T wave, which is the repolarization of the ventricles, which create T wave. And now, if you look at this and this EKG, let's start with this. This is the EKG of the myocardial infarction, where the high elevation of the ST segment. So now I will go back to the ST segment. Here, this is the ST segment. This is the QRS. This is the ST segment, which is should be level with the P wave, PR segment. And now, if you look at that, this ST segment is really, really high. It should be somewhere around here. That is the myocardial infarction, one of the features of myocardial infarction. And now, if you look at that, if you look at the space here between the QRS, the space is 1, 2, 3, 3 spaces wide, and here 1, 2, 3, 4, nearly 5 segment wide. So you can see the difference here, and you can see the just no effective P wave depolarization. It is just the movement here, and you can see the P wave here. Now you lost the P wave here again. This is a condition of the atrial fibrillation, which is very common condition. So I'm going to stop here, guys. I hope you will go and listen to the video again. Thank you.